Hello, I'm Kareem Salhiyyah, consultant cardiac surgeon. Today we're going to discuss aortic valve replacement through catheter valves, also known as TAVI or TAVR. We have discussed previously aortic valve disease and the indication for valve replacement. This can be done through open heart surgery or the minimally invasive approach to replace the valve. But over the past 10 to 15 years, a new technology has become available that is called TAVI or TAVR, and it stands for Transcutaneous Aortic Valve Implantation or Replacement. The first TAVI valve was implanted in 2002, and since then the technology has improved quite significantly. TAVI valves were only available at the beginning for very high or inoperable surgical patients. With the improvement of technology, we now can offer TAVI to a wider range of patients. How does a TAVI valve differ from a surgical valve replacement? Surgical valve replacement require opening the chest and putting the patient on the heart and lung machine. But TAVI valve does not require that. It is a tissue valve that it is made on a special metal frame, and this is compressed over a balloon. The valve is inserted through a blood vessel, usually from the groin. It goes all the way to the heart where the diseased valve is, and once the balloon is inflated, the valve will compress the previous valve and it will open in place. There are different routes to insert the catheter with the valve. The commonest and probably the best one is through the femoral or the groin vessel. But sometimes due to calcifications or narrowings or bending, we can't go through there. So we have to use alternative routes. Some of the other routes are going from inside the chest, it's called transapical, or through some of the blood vessels in the upper body, such as the axillary one. There are less common routes that we use for special cases as well. Can a TAVI valve be used for every patient? There are conditions for the TAVI valve to be suitable for a particular patient. This includes free of calcification, narrowing and bending on the major blood vessels, including the femoral artery, so the catheter can be inserted. Also, there should be a degree of calcification on the native valve, so the valve can actually find something to attach to. If the ring of the valve, or we call it the aortic annulus or root, is dilated, then the valve will not be suitable to fix. In certain conditions, the distance between the coronary arteries, which is the arteries that give blood supply to the heart, is very close to the valve, so putting a TAVI valve jeopardizes the blood supply to the heart, and therefore it will not be suitable in that case too. Therefore, as part of preparing a patient for a TAVI procedure, we have to perform a CT scan that looks at the heart and the major blood vessels to see if a patient is suitable for the TAVI procedure or not. What are the long-term durability of the TAVI valves? We now have data of over 7 to 9 years suggestive of good functioning TAVI valves. However, they still remain a new technology, and we do not know a lot about the long-term durability and efficiency of those valves. Of course, in the future, we will get to know more about the durability and the difference between the TAVI valve compared to the surgical valve replacement. What are the risks of a TAVI valve? Similar to surgical aortic valve replacement, TAVI is a major cardiac procedure. It shares most of its risks with a surgical replacement. However, it's always important to remember that a surgical risk is always decided based on an individual patient and proper and meticulous analysis of their condition. Generally speaking, the risk of a TAVI procedure include most importantly the risk on the life and the risk of a major stroke. Other risks include bleeding, major injury to the blood vessels, problems with the kidneys or the lungs, the need for a permanent pacemaker, and also problems with the leak of blood back to the heart from outside or around the valve cage. This is very important for the future. In very rare cases, there are major problems such as movement or dislodgement of the valve, which could require emergency open heart operations. Due to the way that a TAVI valve works, where it actually expands at the site of the previous valve and it crushes the previous valve to the sides, there could be potential space between the calcium particles to allow blood to leak back into the heart. And this is what we call paravalvular leak. This leak can be mild, moderate, or severe. It is estimated that moderate to severe leaks are about 1 to 5% from all the TAVI valves, while a mild to moderate leak can be as much as 30 to 35% of all the TAVI valves, and this could be significant. Previous studies have shown that a significant leak, moderate to severe, has a big implication on the function of the heart and can increase mortality on the long term. Regarding the mild to moderate leaks, we still do not know the exact long-term effect on those. Finally, TAVI valves have significantly changed the way that we treat aortic valve disease, and they brought a fantastic technology. However, the decision to choose a TAVI valve is far from being a simple one. This should be done through what we called a heart team, which is a specialized team that consists of many members, including a cardiologist, a cardiac surgeon, and many others. They assess the patient in details, decide on the potential long-term, short-term benefits and complications. This subsequently will be discussed with the patient to choose the best outcome for them.